right, so the last chapter we'll cover in our trauma unit is going to be shock. This is kind of a mixture. You can have some shock for some trauma reasons, but you can also have shock for some medical reasons. So we'll talk about all these different types of shock. So basically what we mean by shock is a kind of global hypoperfusion. It just means something is wrong with the body and blood is not going where it needs to go. And that can be from anaphylaxis or blood loss or various things. Basically, there's kind of three stages of shock. Initially, the body's going to compensate for that loss, and then it's going to basically give up and save the brain and the lungs. And then after that, it's pretty much done. So there we go. So you can have it from all variety of things. And this is, they're not wrong on this slide. Basically, just kind of assume every patient is in shock or may go into shock. So always keep an eye on that. And that's always something that should be in your head, is that this patient might go into shock. So we have blood that goes around and it exchanges oxygen, carbon dioxide, and waste products and all that fun stuff. That needs to happen for us to survive. And if that exchange of stuff isn't happening, then we don't survive. So and this is something that prevention is key. It's a lot easier to kind of do some things early on and manage it than to wait until it's too late and now you're playing catch up. And it's once a person is in an advanced stage of shock, it's usually pretty hard to turn around. So all parts of shock, no matter what kind of shock we're going to talk about, all comes down to these three things. Okay, so it's the pump, which is our heart. So the pipes, which is all of our blood vessels and everything, and then the blood itself. Okay, so these are the three components of it, and the different types of shock deal with these components. So there you go. When we talk about the vasodilation, we're talking about those arterioles and those venules and those capillaries. So there you go. You can pause this if you want. It's just showing that these are the three parts of the perfusion triangle, and all three of these things need to be working. And as soon as one of them stops, then we're in trouble. So there you go. So it's just that thing of the earlier picture. So those capillaries and everything, that's controlled by autonomic nervous system. And normally, we will adjust that based on heat or cold or need for oxygen and waste removal. So we need to have all these things going on in the body. Okay, cool. So now we're going to actually talk about different causes of it, right? So this is right here on the table 10-1. That's the types of shock that we're going to be familiar with. Okay, so this will be on the exam. You got to know it. As an EMT, if there's one thing you could learn and you should memorize, it's going to be these types of shock. You have to know the signs and symptoms and actually what's going on for all these various types of shock. So we're going to talk about all of these. All right, cardiogenic shock, easy one because it's the name tells us what's going on. Cardio, heart, genic, generating from, right? So it's shock, but it's because of something is wrong with the heart itself, with the pump. And a major effect of that is the blood's going to back up into the lungs because the blood is going to hit the heart. It'll start to go into the lungs, and then it's going to hit that traffic jam, and then you're going to big build up. So there you go. That's just showing that pulmonary edema, that fluid backs up, and now you're not having that exchange. So there you go, cardiogenic shock, basically heart failure. All right, obstructive shock. And there are two examples of obstructive shock that we need to know. So this is, and it's also another easy one, the name helps us out, obstructive. It's obstructing. Something is affecting the heart and it's obstructing it from working. And the two biggest examples of that are cardiac tamponade and a pneumothorax. So cardiac tamponade, we've talked about this briefly earlier in class, but basically we have this pericardium, which is this little grocery bag sac thing that covers the heart. And it really, there's not a lot of room in there, right? And so once you have even as little as 50 milliliters of blood or fluid in that pericardium, now the heart's not going to be able to beat. Or it's into pneumothorax, and that air gets inside the chest cavity and that air bubble presses against the heart and the heart can't beat. Okay, so both of these, pericardial tamponade or tension pneumothorax, there's something in the way the heart is trying to beat, but it can't. All right, distributive shock. So this was a little bit more of a generalized term. So this is that widespread dilation of those small arterioles and venules. And so the blood, all of a sudden, there's a lot more room now for the blood to occupy, and it occupies that space. And now there's less circulating blood. So an example of distributive shock would be septic shock. Luckily, the name helps us out a little bit. Septic, as in sepsis, as in severe infection. So we'll see this with surgeries or illness or even some injuries, some like infected injuries. Basically, the toxins, the buildup of those toxins from that infection, damage vessel walls, the increased cellular permeability, which just means fluid and cells are going back and forth a lot easier, and the vessel walls are not able to contract. And generally, it's always after illness, injury, surgery, something like that. All right, neurogenic shock. This is it's kind of like spinal shock. There's actually a different term. Spinal shock and neurogenic shock are slightly different, but for our purposes, well, we can call it the same. Basically, it's damage to the spinal cord that results in that widespread dilation. So our spinal cord is the information highway, and there's information going up and down, and at all times, our arteries and veins are contracting or dilating, and the heart's beating and all those things. But if you sever the cord, that information is not going to get there, and now have that dilation. Because normally, our body has to tell us to keep things contracted. Right? Its normal state is dilation, which helps us out. Because if the normal state was being constricted, that's not going to really help us out in times of need, right? So we actually kind of want to be dilated, which just means blood flows a little bit easier when things are dilated. But normally, our body's going to regulate this. However, with a spinal cord injury, that information that regulates all that is just not there anymore. So now you're going to have widespread dilation because of that injury. All right, anaphylactic shock, we talked about this before already. We can kind of go through it. It's some sort of allergic reaction builds up in the body, and the same thing happens. The arterioles and the venules and everything, they dilate, they get really big, and now there's less circulating volume. We already talked about this. Those are some of the things that can cause anaphylactic shock. And signs are very distinct, can develop very quickly. So most anaphylactic shock situations are very, very quickly. All right, and so there you go, signs and symptoms. We've already spent a whole other chapter on this, but if you want to review, you can pause this real quick and read that. All right, psychogenic shock. I mean, yeah, it is shock because technically the blood's not going where it needs to go, but this is like a temporary problem. So this is like a sudden reaction of the nervous system in response to some bad news or something like that, and temporarily everything will dilate, person will pass out. But then once they're on the ground and their body kind of recovers, they'll be fine. So for the most part, psychogenic shock isn't as scary as some of the other ones. All right, hypovolemic shock. This is that big one from blood loss. This is what kills people from bleeding because we lose the fluid. You can also have it from dehydration, like things like vomiting, diarrhea, stuff like that. So they break it down to hemorrhagic or non-hemorrhagic. That's fine. So hemorrhagic just means blood loss from like an injury, from a wound or something. And non-hemorrhagic is your typical dehydration. So vomiting, nausea. All right. So kind of a crazy slide, but this just shows kind of the steps and how it goes. And we on the test, we're not going to talk about the catecholamine surge or any of that kind of stuff. But this is just kind of the flow chart of how shock works. I put this in here for the blood loss thing. There was every once in a while, like every few years, it comes back that we should put tampons in the gunshot wounds, and that's really not backed by a whole lot of science. But some people do love to talk about it. So anyway, so if you do hear that or see it on something, generally we are not treating gunshot wounds with tampons. All right, so 3 stages of shock. This is what I was talking about earlier, very important stuff. You got to know these 3 stages because this is, you might encounter a patient in any one of these stages, right? So you need to know what to look for so you can kind of figure out where this person is at. So compensated shock, like the name says, compensated, the body is trying to make up for it. So usually it's gonna, the heart is gonna beat faster, you're gonna have a little bit of constriction in the arteries, and assuming it's not a spinal cord shock or anything, but your body's going to be doing some of the constricting. It's going to do what it can, and then you can compensate for a little while. But if it doesn't get treated or there's blood loss still going on or whatever, then you go to decompensated shock, and this is late when the blood pressure really starts to fall, and in fact it might fall so much that you will not have distal pulses. Decompensated shock, no radial pulse. So that's a very important key, no radial pulse. And that's because the heart is the blood is going from the heart to the lungs to the brain. That's it. That's all the body knows. Okay, I need these three things to survive. Screw everything else. So if you encounter a patient who's got some blood loss or something and you check a radial pulse and there isn't one, this person is in decompensated shock and they're in a lot of trouble. And then irreversible shock, it's just basically irreversible. Like, yeah, they're still alive, but there's so much damage and so many things have happened that this person's probably not going to come back. Okay, so there you go. Compensated shock, you're going to have some of those things, altered mental status, weak rapid pulse. It could be absent normally, though it's more of a decompensated thing. Nausea, vomiting, marked thirst. Now, once you're into decompensated, now the blood pressure is going to fall to really dangerous levels, some weird breathing, cyanotic skin, absent peripheral pulses, that kind of thing. Blood pressure may be the last measurable factor to change just because that's like the most important thing, right? Once that blood pressure changes, well, okay, there's really, now that person's in a lot of trouble. So you have to really keep an eye on that blood pressure. All right, so like I said before, you kind of want to just suspect shock in a lot of patients, but specifically these patients here. You can think about shock when you encounter these patients. So multiple fractures, they bleed a lot. Abdominal chest injuries, same thing, they bleed a lot. Or you could have air or blood into the chest, and that's causing that obstructive shock. Spinal cord injury, we talked about that. Severe infection, septic shock, or like major heart attack would also be considered cardiogenic shock, or anaphylaxis, that'll be reaction. Okay, so we have a pulse rate, normal pulse is 60 to 100, right? So if you encounter a patient who's got a pulse rate of over 100 and they're just sitting there, that's a red flag that something is wrong. And like I was saying earlier, the prevention is really the name of the game here. Once they're down the shock spiral, it's really hard to pull them out. But these patients are definitely unstable, and we're going to check vitals every 5 minutes and get them to the hospital as quick as possible. So for cardiogenic shock, these patients don't always require blood or IV fluids or anything like that because potentially all that stuff's good, right? The fluid's good, they got blood, the pipes are good. It's just that something is wrong with the pump itself. So we do like to have them sitting up though, because when they're laid back, that fluid can spread out a little bit more, and usually those patients are going to report difficulty breathing when they lay down. All right, so nitroglycerin, we talked about this for heart attacks. Nitroglycerin is a dilator, it's a vasodilator for the coronary arteries. And that's usually something good to give, but once again, it's medication, so we want to talk to medical control and make sure that we're doing that right. So patients who have low blood pressure, weak or irregular pulse, cyanosis, anxiety, nausea, really no one knows the breathing status better than that own person does, right? So however they want to sit, if it's easier for them to sit and lean on the left side, or who cares? As long as they're comfortable and they're breathing good, let them sit however they need. Now you can assist ventilations if you need to. And also have some of that suction nearby because they may end up throwing up. All right, pericardial tamponade. Well, there's really not a ton we can do in the paramedic class I'm taking right now. You can actually do a pericardial needle thoracentesis, which just means I actually take a needle into the pericardium and I actually extract that blood from the pericardium. Obviously, that is something that should be done in the hospital. Lots of opportunities for bad stuff to happen there. So there's not a ton we can do in the ambulance. This person needs some oxygen, and they need to go to the surgeon. They need to see a surgeon. Same idea with tensioning with thorax. Now we can cover the wound. If there's a wound and there's air into the chest cavity, we can cover the wound with occlusive dressing. And occlusive just means that like air is not going to go through it. So plastic bag. There are fancy chest seals, and you can buy them on Amazon or whatever, sure. But you also have plastic and tape. So however it works, as long as you're keeping the air out. Now, the more advanced management is you're actually going to poke a needle into the chest and you're going to let that air escape. But that is beyond the scope of a EMT. And regardless, that rarely fixes the problem. That will buy time, but most likely that person's going to need a chest tube. It's going to be a whole thing. So same idea with cardiac tamponade. Not a ton we can do about this. We have to be aware of it. This is a very serious patient. And we have to take them to the hospital as quick as possible. So septic shock, same idea, just not a ton we can do in the ambulance. Hospital management is required. So oxygen, ventilator support if you need to. Definitely use blankets, conserve body heat. That's always a good idea. But these patients are going to need massive antibiotics and all sorts of stuff, and maybe wound debridement, things like that. And we just can't do that. All right, neurogenic shock. Hospitalization will be required for a long time. Most likely, people with cord injuries, that's kind of a permanent problem. There's initially, though, that's what we call it spinal shock. Initially, the first like 24 hours, the person might actually recover a little bit because the body's trying to like fix itself, and you might have a little bit of return in certain abilities within like 24 hours or so. But after that, whatever that person's disabilities are and dysfunctions as a result of the spinal shock, that's kind of what they have now. That's their normal. So make sure their airway is nice and open, and they're breathing. Spinal mobilization, because there's something wrong with the spine, so we need to fully immobilize them. Assist breathing if we need to. Conserve body heat. Provide effective circulation. Just do what we can to help those people out. Normally they're going to get IVs and stuff, so paramedics will be starting lots of IVs, lots of fluid. Some of these with a neurogenic. So we have the fluid, but it's kind of trapped in the venules and stuff. So we push some more fluid, and that way you can up the blood pressure a little bit just in time to get to the hospital. But these spinal cord injuries are very tough to manage. They might need all sorts of medications, long-term hospital stays. All right, anaphylactic shock. We know this one. We've talked about it a ton. Administer epi, just an EpiPen right in the leg, and give oxygen, and that's it, and take them to the hospital. Any one of these patients, after doing an EpiPen, even if they start to like seem better, I'm still going to want to take them to the hospital because we don't know exactly, especially if they don't know exactly what's happened, like they don't know why they had an allergic reaction, definitely need to go to a hospital. All right, psychogenic shock. I mean, like I said, it's usually fine. A person will pass out, they'll fall down, then things will kind of restore to their normal settings, and they'll be okay. So granted, now if they fall, hit their head, that now we have a whole different thing. But for the most part, there's not a lot of treatment of psychogenic shock. It's just kind of keeping an eye on them, and potentially though, like make sure they just stay seated. So if they passed out, then and they start to feel better, to keep them on the ground, keep them in a chair, something like that, because we don't know. Maybe they'll think of that thought again, and they could pass out again. So that one's going to manage. So there you go. Now, there you go though. So if the patient's unable to walk normally, or there's some other injuries, suspect he might have hit his head on the way down, and now that's like I said, now that's moved on to a different problem. All right, hypovolemic shock. The number one thing we can do here is control external bleeding. So that's tourniquets, pressure bandages, all that stuff. Splint any bone and joint injuries, so that can help reduce some pain and reduce the potential for further damage. Right, if you've got a wrist that's been broken and it's flopping around, you can have some damage with that. But if you splint it, you're going to reduce that damage. Maintain the airway and take the hospital as quick as possible. So this just means that for all these types of shock, you could have respiratory insufficiency, which just means that they're not breathing enough. That the ventilation, like the rate isn't making sense. They're not getting quite enough. So we can give them some oxygen that can help that. So basically, this is like the main types of shock we talked about. So I would pause this. This is it right here. And now on the chart here, you can see increased SVR, which is systemic vascular resistance. You don't need to like know that. I don't think that's gonna be on the test, but really it's gonna be those on the left, the kind of middle block. If you notice, the first word in all these types of shock is hypotension, as in low blood pressure. Okay, so you cannot have shock if you have a normal blood pressure. Shock, by the very definition of shock, is low blood pressure. Okay, so tie that together in your head. Shock, low blood pressure. Okay, so that is a quick down and dirty, about 20 minutes on the different types of shock. Just be familiar with it. So I might ask the question, a patient recently recovered from surgery. Now they're having hypotension, breathing difficulties. What do you think is going on? Well, that'd be septic shock, right? Or there's a patient who is suffering from obstructive shock because there's air in the chest. Well, what's that called? Tension pneumothorax, right? So just be familiar with the ins and outs of those different types of shock, because I might describe a shock type to you, and then you're going to have to figure out what it is. So this will be the last chapter for the trauma unit. Moving forward, we'll talk about just kind of finishing up on like birth and kids and old people, stuff like that. So we're almost done. So hang in there.